Morena I te whānau. Tai hoa. Ka pai morena. Ko Dr. Diana Kopua tēnei e mihi kawana ki a koutou. I rungi tēnei wahanga o te marama, te mutunga o tēnei tau. Anei ahau e pānui ana tēnei pukapuka, e pāna ki ngā rongoa, mō tātou e wangawanga ana pia. Ooh, I don't want to say e mawiwi ana. I'm sort of moving away from that sort of language, but this is a book by Dr. Diana Moncrief. We're up to reading number 17 in chapter 4, looking at the, hang on, wait, it's weta, tino weta. Whew, that took a bit. Okay. So I've really enjoyed reading to you. I hope those who are tuning in are enjoying it just as much. I think it's a fairly fair book. This is not, my disclaimer is if you're on psychiatric medication, this is not me saying get off it now. This is me saying that we must have knowledge and be informed so we can make informed decisions. And so we've gone through a few chapters now, and this is quite a long chapter, chapter 4 about antipsychotic drugs. Talked about the positive and negative symptoms of schizophrenia. If you are just tuning in for the first time, this language, Joanna already talks about how the language isn't language that she supports, and it would be useful for us to change that, but that she found it hard to be able to use a different language so that everyone knew what she was talking about. So in this chapter, positive and negative symptoms of schizophrenia, what do antipsychotics or major tranquilizers do? The newer antipsychotics, the effects on symptoms, and are antipsychotics really necessary? And then we talked about the long-term use of antipsychotics yesterday, and I'm going to talk about patterns of symptoms today. I think that's where we got to. I think. I could be wrong. Wait. Yeah, I think it is. Or maybe I didn't. No, I did. Yeah, all the studies yesterday that talked about long-term use of the medication, and some of those studies we're not familiar with. So I was really happy to share that yesterday. You can purchase this book. It's part of a series of books. I keep forgetting to bring the other one. This is another one, Children's Mental Health Problems. Here's another one, A Psychiatric Diagnosis by Lucy Johnston. They have come up with a new framework, Power, Threat, Meaning framework, as an alternative to move away from biomedicalizing and to demedicalize distress and concerning behavior. So let's get on with the patterns of symptoms. People who are given a diagnosis of schizophrenia or psychosis actually have a large array of different sorts of problems. The symptoms people show vary considerably between individuals, and the pattern of the condition varies too. Some people suffer from discrete episodes when they lose touch with reality, They start to think and behave irrationally, and after a period of time gradually return to normal. Other people experience symptoms all or much of the time, and the symptoms often fluctuate from day to day or week to week. The considerations involved in taking long-term treatment in these situations are quite different. Yet research trials rarely distinguish between people who have made a full recovery and those who continue to experience symptoms. Additionally, it may be difficult to differentiate between people who have made a natural and complete recovery and those in whom antipsychotics or other drugs are suppressing symptoms or problems that would otherwise emerge. Someone who makes a complete recovery has to decide whether it is worth taking drugs in order to reduce the risk of having a further episode. Since we cannot predict with certainty whether someone will have a recurrence in the first place, or how frequent the recurrences might be, a policy recommending that all or most people should take antipsychotics on an ongoing basis inevitably means that some of those who end up taking them might never have experienced a relapse or might have experienced very few further episodes. For such people, the adverse effects of antipsychotics are likely to outweigh their potential benefits. For people who experience continuous psychotic symptoms, taking antipsychotics on a long-term basis may be helpful in suppressing these symptoms to a manageable level. However, in theory at least, any ability the drugs might have to do this initially could be lessened as the body adapts to them, as demonstrated in animal experiments. Some researchers have suggested that prolonged use of antipsychotic drugs can in itself worsen symptoms of psychosis. This is referred to as supersensitivity psychosis. The proposed explanation is that the body's response to the presence of a dopamine blocking drug overshoots, so that net dopamine activity is increased rather than reduced. This is also believed to be the mechanism that produces tardive dyskinesia. Some researchers suggest that supersensitivity psychosis is common in people taking long-term antipsychotics. However, the significance of the disorder is uncertain because it is identified in different ways in different studies, and because it is difficult to distinguish between an exacerbation of psychotic symptoms caused by drug treatment and one that is part of the natural course of the disorder. We are also unsure of the exact mechanism, and if it occurs, it is likely to involve changes to many brain systems and not just dopamine. Mōrena everyone, mōrena koutou, mōrena kora, mōrena Diane. Use of antipsychotics in other situations. I'm almost dreading reading it. Wait. Antipsychotics may theoretically be useful in people who are hyperactive, agitated, or aggressive by reducing physical movement, arousal, and emotional intensity. Trials of the use of antipsychotics for the short-term period of aggressive behaviour show their effects are comparable with those of other sedatives. Trials of longer-term treatment for challenging behaviour in people with learning disability and dementia find little or no benefit. Studies indicate that antipsychotics have no effect on the core features of borderline or emotionally unstable personality disorder, but NICE guidelines suggests short-term use can be considered for crisis symptoms, such as impulsivity and aggression. If antipsychotics are useful in this situation, it probably reflects their impacts on arousal and emotions. There is a lack of evidence for the use of antipsychotics in insomnia, and limited evidence for their use in anxiety. According to a recent meta-analysis, the antipsychotic quetiapine has a modest effect, which is not surprising since quetiapine is strongly sedating and similar to the benzodiazepines, which are recognised to relieve anxiety. Like other antipsychotics, quetiapine has serious adverse effects, however, and the authors of the meta-analysis concluded that the benefits are not significant enough to justify its use in anxiety. The results of the individual studies were also inconsistent, and all of them were funded by the manufacturer. Trials of other antipsychotics for anxiety show negative results. There are studies that show that some antipsychotics are more effective than placebo for people diagnosed with depression, but as described in Chapter 5, almost any drug with noticeable effects has been found to have antidepressant effects in one study or another, strongly suggesting that antidepressant effects are in fact active placebo effects. Overall, since antipsychotics are associated with serious adverse effects, especially when they are used long-term, the balance of benefit to harm is not likely to be positive in situations in which other treatment options or approaches are available. Okay, it's our time. Feel free if you've got any questions. I will keep reading for another 5 minutes. I'm looking at common adverse effects. Extrapyramidal side effects. This term refers to symptoms that are produced by the effects of the drugs on the extrapyramidal system of the brain, which controls involuntary movement and posture. They are caused by the dopamine blocking effects of antipsychotics. They include muscle stiffness, and tremor, sometimes referred to as Parkinsonism, due to the similarity with symptoms of Parkinson's disease. Acute dystonia and uncontrollable muscle spasm, usually affecting the head and neck muscles, which occurs within hours of someone taking an antipsychotic drug and is potentially fatal if not treated quickly, and akathisia, akathisia, a state of intense restlessness that causes people to feel compelled to move about and is accompanied by feelings of psychic tension and anxiety. Tardive dyskinesia. This syndrome is also likely to be a result of effects of the extrapyramidal system. It occurs after antipsychotics have been used for months or years, and the hallmark sign is the presence of involuntary movements, such as lip smacking, tongue movements, and facial twitches. These can persist for years and even decades after the drugs have been stopped, although they may improve in some people. Several studies suggest that a degree of mental deterioration is part of the syndrome. This has led some experts to conclude that tardive dyskinesia is a condition of drug-induced brain damage that is manifested in abnormal movements and a decline in mental abilities. Estimates suggest that tardive dyskinesia occurs in 5.5% of people taking older generation antipsychotics per year and 4% of people taking second generation antipsychotics. Ultimately, it will affect 13% and 30% of people who take antipsychotics on a long-term basis. depending on the type of antipsychotic and the dose taken. It occurs more frequently in the elderly. Brain shrinkage. It has now been established beyond doubt that antipsychotics cause the brain to shrink. 2 studies conducted with animals, one with monkeys and one with rodents, found that animals who were given antipsychotic treatment for a few weeks or months showed a larger degree of brain shrinkage than animals who were given a placebo. In the monkey study, the brains of drug-treated animals were 10 to 11% smaller after 18 months of treatment than the brains of monkeys given the placebo. Studies of patients confirm that the amount of antipsychotic people receive predicts the amount of brain shrinkage they show. A randomized trial of olanzapine versus placebo for the treatment of psychotic depression also showed that olanzapine was associated with greater thinning of the tissue in the cortex of the brain, the largest and most important part of the human brain, compared with placebo. Now that can be found in the study by Voineskos, Voineskos et al. 2020. Apologies if I'm saying that incorrectly. These findings undermine long-standing claims that people with schizophrenia have smaller brains or that schizophrenia itself produces brain damage, since the evidence for these claims consisted of studies of people already taking antipsychotic drugs. I think I'll stop there. There's more metabolic abnormalities, effects on the heart, hormonal abnormalities, and increased mortality. It reminds me of a woman from Ngāti Toa in Wellington Hospital. I was a junior doctor, already had been nursing for a decade in mental health down in Wellington, and I worried about her because she was in seclusion, and she had diabetes secondary to her medication. So wow, she was in seclusion, which means she's coerced, forced into healing, and the healing involved restraining her through her environment. And you have to put her under the Mental Health Act before you can put her in seclusion. So we then take all her rights away from her, and coercive treatment is, or the Mental Health Act, coercive treatment is synonymous with chemical restraint. And so the chemical restraint was giving her antipsychotics. And if she wouldn't take them orally, then it would be an injection. And of course, this was causing secondary metabolic problems that we'll talk about tomorrow, diabetes, and she refused to take medication for that. And my superior, lovely guy, but his argument was, to me, was that the benefits outweighed the disadvantages. So her blood sugar levels were through the roof, and she refused to be treated with them. Oh, more than the Patrick. More than everyone. Yeah, Kieran, really sad, all these long-term effects. I think many of us have seen them, right? And if you're going into a placement as a tauira, it's overwhelming. And then what happens is that you acclimatise and get used to what everyone else is used to. And after decades, you end up justifying it and rationalising your behaviour. Kieran, I do think that there's a place for us to think about describing clinics, and I'm really interested in creating a describing clinic, and I think it can be virtual. I don't think you need a GP clinic. I don't think you need to pay for a big base. I just think that we need a group of like-minded doctors, GPs included. There are many GPs with a special interest in mental health. Dr. Sarah Shasha is one of them, down in Porirua, and myself here in Gisborne, and describing carefully together and not in isolation. And there are some experts around the country or around the world who are studying the impacts of discontinuation and how to go about doing that. And so I think that would be, I'm interested in that. So watch this space. Watch the space. Even nurses, right? It could be a new service. It could be a new operating service, a describing clinic that has nurses and niwareka, so take away the word nurses, but have people who are interested in this information and following studies over 7 to 20 years showing that quality of life is improved for those who don't stay on the medication long term. Now, if you have a whānau member who's on that medication long term and you're interested in discontinuing or tapering, we call slowly taking the medication away, slowly as tapering. Tapering the medication requires your GP or the prescriber or both, and to work closely together with whānau. And the reason that I say whānau, I mean network. I don't care what your whānau consists of, but often when we want to come off the medication, often in life, the things we know and to be true that we communicate to our GP or our doctor might be slightly different from what our whānau know or see. And so how wonderful to have a group of people researching the behaviour and the thoughts. They don't make you up. They aren't you. They're just everyone observing some of the ways of being that you're showing. And I think it's important because tapering off the medication, if there's a reason to slow down, like lots of stress going on in your life, then it's really important to slow right down. And tapering medication to discontinuation can take months and sometimes years. Ngā mihi o te ata, what a depressing subject, hey? I hope it's helping. Ngā mihi o te ata, kia pai o koutou rā, ngā mihi. Yeah. I know, Siobhan, I know. And I was right there probably with you, encouraging you to think about ways of getting him to agree. And lucky he refused. Yeah, I tell you, it's a bit like our Māori men that like their bacon and eggs, and we try and tell them to eat salad because that's what the doctor told us is healthy, and now we're finding out that actually fat is really good for you and carbohydrates. It's really important to have low carbs. God, our men knew to refuse, right? Now, I'm generalising. I said goodbye. I better go. See ya.